like. So we are going to have these conversations in this webinar and the upcoming ones with that holistic view that surgery, as I say, and surgical care is all encompassing. And also, we want to say on behalf of UNITAR mainly that the NSOAP manual is meant to address country priorities, and particularly developing nations. Those country priorities should include a broad range of specialties, including, as I say, anesthesia, OBGYN, surgery properly, and many of the surgical subspecialties that we are going to discuss about, and the whole surgical ecosystem, for lack of a better word. So this is not a vertical approach. This is, as I say, a holistic approach to surgical care, and perhaps a little more horizontal in a way. Now, to conclude this short introduction and to welcome you properly, I would like to recognize particularly Dr. John Merritt. John, our good friend and colleague here at the United Nations at UNITAR, he's the director of the program in global surgery and social change at Harvard Medical School. John and his team are actually the people that put this together. And yes, UNITAR has been able to contribute, and we will help mostly in the delivery, but without John, we wouldn't be here either. And last but not least, allow me to acknowledge on behalf of my Assistant Secretary General, Mr. Nikhil Seth, who is going to preside from this moment on, this webinar. I also would like to acknowledge Dr. Jeff Evelson. Jeff, it's been a privilege to have you at UNITAR. He is a senior advisor on issues of public health and surgery, and at the same time, he is the executive lead of the Global Surgery Foundation. We have a all-encompassing multidisciplinary team today, and we also welcome Dr. Emmanuel Macasa, a good friend of the United Nations and of this process, and Dr. Salome Maswine, also with quite an outstanding experience that caused an impressive reaction today. Salome, Dr. Maswine, you are, of course, most welcome here. With those general comments, I would like to offer the floor now to my Executive Director and United Nations Assistant Secretary General, Mr. Nikhil Seth. Mr. Seth, the floor is yours.
Hello, everyone, and thank you for joining us on this special occasion of the launch of the manual, the NSOAP Manual. And of course, at the launch, we can turn our minds not only to the launch of this manual, but what lies ahead for us in the area of global health and specifically global surgery. The world these days is preoccupied with the issue of global health in all its dimensions. The COVID-19 has brought that brutally to our attention, the lack of global public health, and we've often neglected the importance of surgery and the role that plays. But before I speak a little about these issues and how closely they are linked to the UN's agenda, which is really achieving the Sustainable Development Goals by 2030, I just wanted to start with my words of thanks. Thanks to the Harvard Medical School, here represented by John Myra, and the more than 50 contributions from various sectors of global health, which have made this publication possible. Now, UNITAR and the Global Surgery Foundation, ably led by Jeff Ibbotson, we are very grateful for your support and work, and of course for making this series of webinars possible. A special word, as Alex had mentioned, to the help we've got from Johnson & Johnson. We are hoping that an exposure to these webinars will help ministries of health in particular, get an idea of the importance of the subject that we are discussing today and increase their capacity in providing surgical services in their countries. As I mentioned earlier, we made a commitment to achieving the Sustainable Development Goals by 2030. The road to 2030 looks extremely bumpy at this juncture, and there's so many boulders on its path, and it's such an uneasy journey to 2030 with the shocks that we are getting repeatedly, whether they are political shocks or economic shocks or social shocks or environmental shocks or shocks in health, which is really at the uppermost of all our minds. But it underscores the importance of the SDGs, and especially for focusing on those that are most vulnerable, the poorest, those living in remote areas who need all the help the world can give them to survive and reach as far as 2030. The provision of safe and affordable surgery is inextricably linked to many of the goals of the SDGs. The loss of livelihoods and income, ill health, which could easily be rectified by simple surgery causes. You all know how important the goal for universal health care, which is one of the targets on the goal of ensuring health for all. You know the importance of the objectives of gender equality and empowerment, of promoting economic growth, of reducing inequalities, and all this through strengthening partnerships. And these are things to keep in mind as we focus on this one issue of global surgery and strong and resilient healthcare systems to maintain healthy populations and economic stability during these periods of uncertainty. As everyone's been saying, given our global interconnectedness, no country can be fully healthy unless we have health systems for all, including in the 92 most distressed countries, which is half the membership of the UN. Half the membership of the UN is from countries which are in conflict, which are emerging from conflict, which are least developed countries, many of them in Africa, small island states, and so on. And unless we can reach these public health systems and make them as strong as the strongest health system, we are not going to succeed in our struggle against COVID 19, future pandemics that might be waiting for us around the corner, and of course, in all the objectives of the global health and the universal health coverage, of which global surgery is an extremely important part. Even without the additional strain which is being caused by the pandemic, lost economic output uh, due to poor access to safe and affordable surgery is going to cost trillions of dollars by the year 2030. Unless access to surgical, obstetrical, and anesthesia care is totally and thoroughly improved, we are not going to get there as far as universal health care is concerned. We've done well in several things over the last decade, and we have reduced the maternal mortality rate by 38% since 2000. We have reduced infant mortality by 44% in these 20 years. But the last mile for both maternal and child health will be greatly strengthened by access to safe surgical, obstetric, and anesthesia care for all. We have lots to do and miles to go before we can rest in this fight. And we need an increased commitment from global leaders to fund the necessary steps to make safe surgery, obstetrics, and anesthesia available to everybody who needs it. And UNITAR is committed to doing what we can to help the world on this path. We are pleased to publish for today's celebration the NSOAP Manual with Harvard, and we feel that with adequate support, this publication can become a key resource in assisting countries to integrate surgery, obstetric, and anesthesia care into their national health strategies. As I mentioned before, COVID 19 has taught us many lessons. It has shown what inequality does to societies. It has shown that those who are on the front line of medicine, how much they get affected and how little society turns to them in normal times, and how much debt we owe all these people. And of course, on the issue of utilizing the NSOAP manual, I invite all of you who are listening today to contribute to the implementation of NSOAP manuals. We have to adapt these NSOAP manuals. We have to talk about them, make them country relevant, and make them appropriate into national healthcare systems. And that's where the success of the utilization of this manual by converting a manual into country specific action plans. Once again, let me say that I'm very happy to be with you at the launch of this manual, and thanks to all those who made this possible. But this is only the first step in a very long journey, and I hope we'll all be able to take the next steps, both at the country level and globally, to make all this happen. Thank you very much.
Thanks to you, Mr. Seth, for those very all-encompassing welcome remarks, and also for calling our attention to sustainable development as a whole. Indeed, we are all involved. Let me now continue with the agenda and introduce properly Dr. John Mera. Dr. Mera is a professor of global surgery, director of the program in global surgery and social change, as I mentioned, and also professor of surgery in the Department of Surgery at Harvard Medical School. Dr. Mera serves as the plastic surgeon in chief of the Department of Plastic and Oral Surgery at Boston Children's Hospital. He was co-chair for the Lancet Commission on Global Surgery and was also commissioner on the Lancet Global Health Commission on High Quality Health Systems in the Sustainable Development Goals era. He has also been part of the Lancet Oncology Commission. Dr. Mera, it's a pleasure to have you with us. The floor is yours.
Thank you very much, Alex. First, I really want to thank UNITAR again for allowing this process to go to fruition, and that includes Executive Director Nikhil Sith and Alex, yourself, and also Jeff Ibbotson. And I also have to thank Julia Genth and Sebastian Hofbrauer. They've been working behind the scenes for weeks now to make this happen, so I'm very appreciative to all their work. And also, as Nikhil mentioned, there are over 50 authors and reviewers and editors that went into this whole process, and I want to recognize all of their work. So thank you all. And now next slide, please. Next slide. So the concept behind this National Surgical Obstetric and Anesthesia Planning Manual really recognizes the importance of health systems at large. So this is not a vertical intervention. So this recognizes that surgical care sits within health systems, and health systems require governments and governance. They require financing. They require data and information management. They actually require hospitals and health centers and a workforce. And then in the lower left-hand corner there, you can see that's the actual care provision. So there are a number of facets to surgical care that is embedded within a health system. And I think you cannot overemphasize that, the importance of NSOAPs sitting within a national health prioritization process. All right, this is not a vertical approach. Next slide. A little bit of historical backdrop. So in 1980, Halfdan Mahler was the Director General of the WHO, and he was one of the first world leaders in health who made the link between surgery and social equity. So you see at the end of his statement there, I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare. One of the first times that someone stood up and said, look, surgery, surgical care, anesthesia care, OB, trauma, etc., has social equity implications. Next slide. 28 years later, you will remember there was a paper that is now fairly famous, written by Paul Farmer and Jim Kim, where they called global surgery the neglected stepchild of global health. And this was in recognition of the fact that maybe in the past it had not received the recognition that it should, given that it should be part of an overall properly functioning healthcare system. Next. And then in 2015, we all know that this was quite an important year for global surgery, in that DCP3 came out and the first volume was on surgery, the Lancet Commission came out, and WHA 6815 came out, which recognized the role of emergency and essential surgical care as part of UHC, as Nikhil mentioned. I'd like to spend just a moment on the Lancet Commission now. So if you look at the Lancet Commission on Global Surgery, it produced really four main outputs. One was a vision, universal access to safe, affordable surgical and anesthesia care when needed. The second is 5 key messages. We were asked by Richard Horton and Jim Kim actually specifically to come out with indicators, and we did that. And then the last concept is why we're here today. So this concept of National Surgical, Obstetric, and Anesthesia Planning. Next slide. So many of you will have seen these 5 key messages. We had an access key message, 5 billion people lack access. We had one message around additional procedures that would be needed. We had another that dealt with financial risk protection and that 81 million people may face catastrophic or impoverishing expense. We had another message on the investment that investing in surgery could be in terms of investing $350 billion, but the economic impact of that could be $12 trillion for emerging economies. And then the last message was a holistic message that surgery is an indivisible, indispensable part of healthcare. And this was actually a quote from Jim Kim in his first address to the Lancet Commission in January of 2014. Next slide. We also came out with 6 indicators, and these were roughly linked to our key messages. So we had an access indicator, a workforce indicator, a surgical volume indicator looking at process. We had a quality indicator looking at perioperative mortality, and actually 2 indicators looking at financial risk protection, recognizing the link between surgical care and poverty. Next slide. And we all know those indicators actually have made it into the World Development Indicators of the World Bank. And here is actually a blog written by Emi Suzuki, who's one of the leaders in the WDI section of the World Bank. And she wrote that with Mark Schreim and I. Next slide. Now, this concept of National Surgical, Obstetric, and Anesthesia Planning. So this came really towards the end of our Lancet Commission. We were discussing this, and I love telling this story because it involves Emmanuel Makasa. We were at a meeting, and Emmanuel was literally texting his Ministry of Health, and partway through the meeting, he raised his hand and told the whole group that he was texting with his government and that Zambia would be the first country to embark on this type of a planning endeavor, which really solidified our commitment to the Lancet Commission, as you can imagine, when he made that statement. So next slide. You can see what happened. So that famous day was in 2015 in February at our Bellagio meeting when Emmanuel made that pronouncement. And then later in 2015, we came out with the publication of the Lancet Commission. And Zambia and also Ethiopia were really some of the first countries to get moving on this concept. And later we saw Tanzania and Rwanda and Pakistan get involved in this. And through a great deal of work on Emmanuel's part, for example, he will talk a bit more about the work that the South African development community has done. And I noticed, I think, go back, please. Just a little shout out to Lubna is on the call from Pakistan. She's been involved in the Pakistan process, and Emmanuel Ame from Nigeria was involved in that process. And then the next thing we saw was that the Pacific Islands became very interested in this, and they've been very much leading a process there along with WIPRO. Next slide. So the other thing I want to mention is that Harvard Med School supported a series of meetings in Dubai. So one was in 2018 that concentrated a bit more on the Afro region. And then the next year we had another meeting in Dubai. Next slide. And this concentrated a little bit more on EMRO and the broader Asia region. And the next slide, I want to show you a video that Dr. Tedros taped specifically for that Dubai meeting in 2019. And well, let's take a listen to what he has to say about this process.
Lord William Itangi, Professor John Miara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen. Greetings from Geneva, and thank you for the invitation to speak to you today and I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
Next slide. So I just saw in the chat box that someone could not hear the video. I will find the direct link to that video and put that in the chat box function after my talk here so that people can listen to that if they had trouble. So what we saw happen next after this evolution after the Lancet Commission and after these Dubai meetings was that this process grew, and it grew locally. And by that, I mean that country leaders took this on, but then regions took this on. And so in the SADC region, we've seen that entire group come together to do something cohesively and holistically. And I won't say more about that because Emmanuel will talk a bit about that. And he's really provided tremendous leadership for that process. Next slide. And then this gives you an idea of what's happened around the world. So you see a number of countries that have actually launched a process, some that are interested / committed, and then a number that are still in progress. And I would mention that surgery, for example, is going to be one of the main themes in the WIPRO, the Western Pacific Region Regional Committee meeting this year. So that's a huge step forward. Now, interesting, on Twitter yesterday, actually, I saw an article that actually had come out in 2019, and I remember seeing this in 2019, but then I reread it yesterday. And Sai Abimbola, he talks about some issues with our approach to global health, and particularly global health publications. And he talked specifically about pose and gaze. And what he meant by that is when people involved in global health, what is their position or their pose? Are they local or they're foreign? And the gaze is for whom are they writing, for example? And again, is it for a local audience and for an international audience? And it struck me that this NSOAP process is both for local pose and local gaze. And what I mean by that is it is run by local leaders and it is specifically for local constituents. So this is not run by foreign folks or for a foreign audience. And I think for that reason, this NSOAP process is almost by definition anti-colonial in the sense that it helps with the process of going through prioritization, but it doesn't define the outcomes. The outcomes are defined by local leaders, by local healthcare providers, by local constituents. Next slide. So I just want to give you a very 30,000 feet overview of the manual, and you will see the contents, for example. This is a very procedural manual in the sense that it doesn't set priorities. What it does is help folks walk through the process. So developing a case, the planning process, stakeholder engagement, monitoring and evaluation, et cetera. So it helps ministries and countries and stakeholders go through the process. But I want to be clear, this does not set out specific goals, because that is really for the countries to decide. So, metaphorically, this is a vehicle, but in terms of the destination, that is for countries and country constituents to decide upon. Next slide. So I'll close with a couple things that I think are key messages for this whole concept of NSOAPs. One is that by definition, it is for local consumption by local leaders and by local providers and local constituents. And to the extent that, for example, we may help, that is really all it is in terms of helping gather information, analyze information, but the prioritization process is local. The second point is that this process should be absolutely, completely integrated into national health priorities. So this is not a standalone process. The goal is not to have some separate thing that sits off to the side. The third is financing. I think as a global surgical, obstetric, anesthesia, trauma, et cetera, community, I think we need to pay a lot of attention to how these processes are financed, not necessarily the process itself, but the end product. So we have seen these plans develop, and I want to make sure that we're, as a group, thinking about how do we finance the implementation. As the executive director, Nikhil Seth, said, and in his opening comments, obviously this process is linked completely to UHC and the SDGs. And then the last thing, which I think is becoming more clear to us, is what is the role of this planning process vis-a-vis pandemic preparedness and global health security? And I think, to be honest, during the Lancet Commission, that wasn't really front in our minds. However, obviously things have changed in the world, and we now know that surgical systems, surgical capacity, surgical workforce has played a huge role in this present response to pandemic. And I think we would be wise to consider what is the role of ongoing surgical strategic planning vis-a-vis global health security. So with that, I would like to thank everyone. And Jeff and Alex, I will turn things back over to you.
Thank you very much, Dr. Mera. Indeed, your presentation serves to put this in perspective, and it's a good call for action. Before we get to Professor Makasa, Dr. Ibbotson will take over and will moderate the rest of the discussion. It requires some technical knowledge. I'm not a doctor or a surgeon, he is. So let me introduce him briefly. He is, as I mentioned, a senior health advisor at UNITAR for the program in health and development. He has more than 25 years of experience in medical, humanitarian, and disaster relief, working several times as a frontline surgeon in conflict zones. He is a surgeon in Canada, now in sabbatical, that served as the director of trauma services for the Northwest of Alberta from 2008 to 2016, and was also the chair of the Alberta Provincial Trauma Committee from 2014 to 2016. He is a graduate of the University of Toronto, and he received his training as a general surgeon at the University of Calgary, and is at the same time a fellow of the Royal College of Physicians and Surgeons of Canada, and also of the American College of Surgeons. Dr. Ibbotson, it's a pleasure to have you in our team here at UNITAR. The floor is yours now.
Well, thank you, Alex, for that very kind introduction, and a special thank you to Mr. Nikhil Seth and Dr. John Mera, of course, real leaders in pushing forward the agenda on global surgery and anesthesia and obstetrics and the whole spectrum of surgical care. So it's my pleasure now to moderate the rest of the session, and I don't want to spend too much time talking because I want to introduce Professor Emmanuel Makasa, who is well known by the global surgery community, and we're very thankful to have him as part of this panel. He, as you mentioned earlier, he is really taking a lead in supporting the 16 member state SADC region and helping them develop the surgical planning for that whole region. I'll let him talk a little bit more about that. interestingly, though, is his role in the resolution 68.15, and he was the global health diplomat for Zambia at the time, and really chaired and led the whole process for that resolution. So we really are thankful for his contribution to the greater global surgery agenda, and we're very, very thankful to have him as part of this panel. So Emmanuel, without any further ado, I'll turn it over to you. Thank you very much.
Emmanuel, I think you are muted. Can you hear us?
He may have dropped off.
I still see him, but perhaps it will be a good opportunity to introduce Professor Maswine now, and then we go back to Professor Makasa.
Exactly, okay. Well, while we're waiting for Emmanuel to get back online, let me introduce Professor Maswine. We're also very happy to have her as part of the panel. And again, a great leader in global surgery. She's presently the head of global surgery at the University of Cape Town and is an obstetrics gynecologist, the president of the South African Clinician Society, and one of the World Economic Forum Young Scientists. She has a long list of accolades and awards over the last many years, and we're very, very happy to have you with us, Salome, and we're quite eager to hear about what you have to share from your perspective in this whole NSOAP process. So maybe what we'll do, Julia, if you could jump to Salome's slides. We'll start with Salome, and then when Emmanuel is able to jump back on the call, we can carry on with that. So please, Salome, go ahead. Thank you.
All right, thank you so much, Jeff. First of all, just to congratulate you, John, PGSSC, Harvard, on this amazing manual and all the work that you've put in. Also with UNITAR, and also just to acknowledge everyone, Jeff, Alex, Mr. Nikhil Seth, and to thank you for inviting me to talk as well. So I'm going to talk about how the NSOAP process will assist frontline stakeholders. And I'm really going to speak from the perspective of a clinician, from the perspective of a surgeon. I'm an obstetrician myself, so I've spent many years in theater cutting. And so, you know, often in medical school, in theater, what you taught is that, you know, it's all about the surgeon and you need to be meticulous. It's about the skills, have the eyes of a hawk. It's actually quite poetic and dramatic how we told to be skilled surgeons, in the hope that how meticulous you are is going to result in good outcomes. But I think now we all know that it's not only about how well the surgeon cuts or how well you've been trained. Where you are and what resources you have play a more important role in determining the outcomes. Next slide. And this builds on some of the work that I've been part of, the African Surgical Outcome Study. And so with all the training that we have and all the skills that we've learned, what we realized when we looked at African outcomes in Africa was that African mothers were 50 times more likely to die after cesarean section than women in high-income countries. And that speaks a lot about the systems and the surgical systems. And I mean, a lot of what John has already touched on really is all about that we need to look at surgical systems and how we can improve surgical systems to get better surgical outcomes. Next slide. And so it's really, if you look at this work from the past century, from William Osler, famous quote, that it's much more important to know what sort of a patient has a disease than what sort of disease a patient has. And that's really starting to contextualize surgical care. And that's what I want to talk about mostly today. So we all know that there are social determinants of health, and there are also structural determinants of health. And that's looking at exactly where the patients comes from, their living circumstances, patients who are poor, who are uneducated, who are not employed, are more likely to have more adverse outcomes or not survive some of the surgical conditions that they may have. They, depending on where you have your accident and injury, might determine exactly what outcome you have. So if you have your trauma in a place where you don't have access to an ambulance quick enough, you might die from an injury where you would not have died in another part of the world. So it's important for us to acknowledge this and to understand it as surgeons, as anesthetists, as clinicians that are working in the field, and to think outside of the theater and what we have inside of the hospital. Next slide. And so here I'm trying to just emphasize that we need to think about how we're going to fix these problems and whether the strategies that we are trying to apply can be applied across disciplines, across countries. Is this a one-size-fits-all type of approach, or do we need to have different approaches? And so just an example, I mean, early in this work on global surgery, there was a lot of emphasis on access and increasing access to care. But for many of us, we realized that it wasn't just about access, it was about quality as well, because some of our patient outcomes in places where access was increased rapidly also resulted in patients dying from complications. And so that I saw in some of my work on cesarean sections as well. So it's important to have a local plan and to develop strategies that are implementable in a local context, and just being contextual about the plans and strategies that we have. Next slide. And so this is where I just want to emphasize that we need local solutions for global problems. And whilst we've identified that 5 billion people have lack access to surgical care, we cannot apply a one-size-fits-all. And that's where the national surgical obstetric plans come into place, because it's local solutions, but looking at a bigger problem and looking at bigger things such as the disparities in outcomes, looking at equity. And so it's important that as surgeons, as clinicians, as frontliners, that we have the context, understand our local context, so that we come up with solutions that are specific to our context as well. Next slide. And so I just want to touch on quickly, if you look at the clinic, who's involved, who determines what the outcomes are going to be. And it's not just, we've often looked at it we often look at it as it's the nurses, it's the nurses, it's the midwives, it's the surgeon, it's the anesthetist, but the human resources involved in all of this, it's much wider. It goes across the economists, the scientists, the policymakers. And I think this time that we're in with COVID-19, a lot of us now understand this a lot more, because we've seen all of these stakeholders. We've seen how healthcare impacts on the economy. We've seen how policymakers are critical in making sure that, certain things are done and that we meet certain targets. And so I'm highlighting this, especially to surgeons who don't often think about healthcare in the context, in the bigger scheme of things, and in the context of all the human resources involved. So next slide. And so in closing, what I want to say is that these NSOAP, the NSOAP plans are so important, because this will allow us to reimagine surgical care in our local context, in different countries, in different communities, allow us to address disparities and look at issues of equity, but finding solutions that are relevant to the local context whilst addressing a global issue. So together as surgeons, anesthetists, obstetricians, as stakeholders across different fields, we need to partner and work together to improve surgical outcomes globally. Thank you very much.
Well, thank you, Salome, very much for that very good overview. And I had seen that Emmanuel had come back on, but it may be that he's dropped back off. He's possibly having some internet problems.
I'm here.
Oh, you're there. Great, Emmanuel. Well, welcome back, and we're so glad that we can have you back online. Julia, please jump back to Emmanuel's presentation to the beginning. And Emmanuel, as mentioned before, you're well known in this community. We're very thankful that you're part of this panel, and please share with us some of your thoughts. Thank you very much.
So thank you so much. I really sincere apologies to all of you for that hiccup in technology, but that's what we go through in low middle income countries. Nothing is stable, not even the internet. But anyway, building on everything that's been presented, I will try and cover the topic on how the NSOAP, or the National Surgical Obstetric and Anesthesia Plan, helps in achieving the goals of the Resolution 6815 that John Mira talked about, a resolution that was endorsed by the UN's specialized agency on health, the WHO, in 2015. And I happen to chair and negotiate and lead that resolution. Please, let's have the next slide. So for those that have never heard of this resolution or have never seen it, the resolution basically talks about emergency the title of the resolution is the main overarching goal. So the goal is really to ensure that we can strengthen emergency and essential surgical healthcare. And the strengthening, so you can see from the framing of the title of this resolution that it's a systems approach. It's talking about systems. It's not talking about surgery standing as a silo, or surgery divorced from anesthesia, divorced from nursing, divorced from everything else that works to achieve this. So it's all encompassing, and it talks about us strengthening. It doesn't talk about us starting from zero, because surgical services have been ongoing, maybe not in a very good way, because there was no global policy, there was no regional policy, there was no national policy in many countries to help. And so to start to do any work, we needed policies that could then guide programs, and then we can go to service delivery. And this resolution was forward thinking. It was endorsed in May of 2015, as you can see from the date, 26th May. And this was way before we even knew what the SDGs were going to look like and what health goals were going to be included in the SDG. So already from a start, the member states were looking forward, and they already knew how they really wanted to move in health system strengthening to achieve universal health coverage, because the issue of universal health coverage was already discussed, and there was already a resolution at the UN or at WHO that talked about what the universal health coverage is. Issues of ensuring everybody has access to everything that they need in healthcare of good quality, without really having to face catastrophic costs that are associated with it. Again, I want to emphasize here, building on what John said, on the issues that are very topical today, colonialism, neo-colonialism. I want to emphasize and indicate that this resolution was a bottoms up, in the sense that it came from the low middle income countries. It was led and tabled initially by the SADC member states, and then supported by the African Union member states and the other colleagues that come from WIPRO, EMRO, everybody else that was facing challenges in ensuring that our people can receive the needed surgical health services. Of course, even in the developed countries, there are pockets of people that haven't received this good service, but mostly, like I said, it was something that came from the bottom. So it's not something that was imposed on us. Next slide. Okay, so when we look at the resolution, what did it really address in terms of specific objectives or sub goals? So there were three pillars really that we built on when we were negotiating this resolution. One of them was the issue of health system strengthening. There's been a lot of discussions, as you know, on health system strengthening, but very little meat on how to do it. So this resolution, looking and focusing on surgical healthcare, knew that we needed to create appropriate policy, because we did not have policies at country level on how we could improve surgical care. If we did have those, we could have gone ahead and just done the work, but we didn't have any. And because surgical service delivery is multi-professional, multi-sectoral, and it has a lot of actors, it's quite complex, and it doesn't sit in one thing. It's cross-cutting. It crosses all health levels of the health system. It crosses all age groups. It crosses all disease areas or disease burdens. So in that way, it's quite a complex process that needed policy to guide on how it can be done. And the policy that we're launching today, or the manual that we're launching today, the NSOAP, is a great policy that came up to be able to guide countries on how they can actually develop programs to deliver services at country level. And so we are very happy that PGSSC, working with UNITAR, has gone ahead and produced this manual, because many countries have been struggling on how they can translate their political commitment as contained in the resolution into something tangible on the ground. The focus of the health system strengthening is the district or first level health facility. When these services are brought closer to the people at that level, there is a bigger chance of many more accessing them than the current scenario where people have to come to the capital to receive services in congested environments. And so it also talks about integrating surgical services, into what is already running on the ground. And as you know, many programs at country level are in silos. So we have the TB program, the malaria program, the NCD program. Most of these programs run alone as silos, all the way from the top to the bottom or to the community. But surgery can't run like that. It's impossible to set up a surgical system that is a silo. By nature, surgery is cross-cutting and has to involve everybody else. So we were aiming to strengthen systems so that we can deliver better in other siloed programs. And surgical services are also important to tie up all these siloed programs together. In surgery, we say surgery is the stitch with which we tie up all the other health programs so that they can deliver better. And it also talks about improving communication and referrals. In low middle income countries, those that have been here or have worked here know that this is a nightmare, and it also contributes to why our health system don't function very well. In surgical services, these need to be improved, and communication is very, very key, especially when we're dealing with emergencies. Finally, the building of capacity to deliver services or to strengthen the health system builds on the pillars of the health system. John Mira already mentioned these, the human resources, the financing, the health information, and the others, the medical supplies and equipment. All those are key, and most of them have never been developed, at least as regards surgical health services at the lower level. So these all get strengthened, because we can't provide surgical services without improving lab capacity, without improving imaging systems, and a lot of other things that are needed to provide safe surgery. So that's how it looks at it from the health system strengthening perspective. When we move then, if we improve the health system, we expect that we should have better health outcomes. Surgical services can save lives and reduce mortality, not only from emergencies like road traffic accidents, emergencies like war and earthquakes, even emergencies, as you know, the COVID-19 pandemic right now is ravaging the world. Like John said, it's our team, or the anesthesia and critical care component of surgical services that's very, very critical in maintaining life for those that are severely affected by COVID-19. So those that can survive and can live through COVID, most of them are being supported by surgical systems to be alive. So it's important that the world starts recognizing the role that surgery can play. And we hope that during this pandemic, we can use this, as it is an unfortunate situation, we can start building capacities, especially in anesthesia and critical care, so that we can also build on this later on to manage our perioperative mortalities and things like that. Surgical services have to be of quality. We cannot provide surgical services that are of poor quality. Poor quality surgical services are worse than no surgery. So improved patient quality and centering the service on the patient is pretty important. And surgical services also contribute to reducing morbidity. Many patients, as you know, for those who have never worked in surgery, most surgical conditions, besides the fact that they can make you lose your life, if they don't make you lose your life, you may end up being physically disabled. And that becomes a pretty problem. And surgical services can help reduce on that disability to improve quality of life. Even in palliative care and rehabilitation, surgical services are key. I have already mentioned how surgical services are also supporting the COVID-19, but I can also mention here that surgical services have been used in the past, even now, to prevent infectious diseases. As you know, medical male circumcision is a surgical procedure. if we want to manage a comprehensive management of non-communicable diseases like trauma, cancers, comprehensive cancer management from diagnosis up to the end involves surgical health care. So if we want better health systems, surgical healthcare can be one of those drivers that can help us with that. And then we can then look at the social economics of it. This is very important for funders. Many people think surgery is very important, expensive, it's not worthy to invest in. But models have been made by funding agencies themselves, like the World Bank, the European Investment Bank, and many academicians have also discussed this in detail. And there's a recommendation that if we provide these services at the district hospital, they are just as cost effective as other public health interventions, such as vaccination. And so it's not true that it's very expensive, but it would be more costly if we don't provide this service there. I already mentioned how it improves, reduces on disability. When this is done, it restores people's, back to work, restores their dignity. If you look at things like difficult labor, where women come out with fistulas, these women are ostracized, they leak urine and feces, they smell, the community doesn't want them anymore. And this is something that can be fixed with 3 hours of surgery so that they can get back and have their dignity that they deserve. So let's look at it like that. And also, like I said, the surgical capacity building involves a lot of human resource training and improvement. We have a lot of gaps in our health systems for surgical health workforce. So, but many countries are also grappling with providing employment for the youth. This is a great area, and the United Nations, through its High Commission on Employment and Health, did recommend that the health sector is a key area where we can create jobs. And we are also recommending that the surgical service system, health, human resource for health, is a key area that can be looked upon for those countries that want to improve and create jobs for their youth. They are very good, well-paying jobs. They are long-lasting, and people can even work for themselves outside the public health system. And again, finally, those that are affected with surgical conditions, usually, like I said, are disabled. And because of their physical disability, especially in the low middle income countries, here we have to use our hands, our legs to earn a living. We can't make money on the computer. And so if we're physically disabled, then we cannot really be economically active. So when we are helped with surgical services to restore our physical capabilities, then we can fend for ourselves and make some money. And then this also reduces the burden of dependency on the family, on the community, and the nation at large. Next slide, please. So John Mira did share a better slide that shows the global progress on the formulation of the NSOAP. So the National Surgical Obstetric Anesthesia Plan for us is a way we can translate the political commitments that are contained in Resolution 6815 into something or a map that can guide how we can handle the complex issue of surgical care improvement at country level. And so that's what it is. The NSOAP guides us on how we can develop that policy at country level. And again, it's bottoms up. This policy is developed by the country itself. It's never imposed. The NSOAP is a framework. The NSOAP Manual is going to be a guide that can guide countries to develop this, because many countries, like I said, are having challenges on how to do that. And those of us that have gone through this process of developing an NSOAP are not so many, and we can't cover the whole world. And right now we can't even travel. So countries have to be empowered. And so we thank UNITAR and PGSSC for coming up with this manual. This slide basically shows most of the countries that have already embarked on this. John Mira already said this, so I will not belabor this point. But these are the countries, including those that are in WIPRO region, and a lot of Latin American countries are already also working on this, but we have not really captured how far they've gone. And so, but the lower middle income countries themselves are taking this forward. You can see it's country driven, and there was a little bit of a gap in terms of global leadership and global coordination. And so we're very happy that UNITAR has taken up this challenge to give that global cap. And we hope that WHO can come on board, and any other international organization or intergovernmental organization that can guide and work with this. For us in SADC, we're very blessed to have worked with our SADC Secretariat and member states, the Southern Africa Development Community, and all of them are committed to do this. Next slide, which should be the last slide. Okay, so where can we go from here? What is missing? These are just my projections. You may not agree with them, but in terms of how we can really get to go and finish this work, we need leadership and coordination. We have many, many, many actors and many, many stakeholders that work in surgical healthcare, globally, regionally, at national level, including subnational level. We need to be coordinated so that we can work together, because there are many stakeholders and there are many actors. Without coordination and leadership, it becomes very, very hard. Again, John talked about the issue of financing. We're having trouble with financing. I think we have to work together so that, for example, I have watched videos in nature, you know, the big fish eat the small fish and the big birds eat the small birds. But the small birds or the little fish can group up and create an image of a big fish that can even threaten a shark. We are, in our individual capacities or as an institution or organization, we're really the small fish. We have to learn to group up so that we can create that big fish and scare away or at least attract the funding that we need and make that impact. There is always success when you unite in purpose. Again, we also need to be targeted. We cannot be shooting all over the place. This one is shooting there, PGSSC is shooting there, UNITAR is shooting in that direction. We have to try and have some targets so that we can achieve those targets one step by step and then move forward. If we have unity of purpose, leadership and coordination, we also need to bring the community forward. So far in this work on global surgery, only the stakeholders, the actors themselves, the people who provide the service delivery, the governments have been the ones that have been very active. I think we've left out the patient, and sometimes we've struggled even at country level to translate what we've already committed to in terms of policy into something that can deliver, because we've left the people behind. We need to get the patients, the population on board. We need to hear their input. We also need to hear their concerns, because we don't know, most of them might be scared of surgery, but we need to involve ourselves in health education so that our community can speak for us. In fact, they are the best advocates. They are the voters. They are the ones that are going to force governments and other development partners and stakeholders to invest in what they really need. So that needs to be done. And then we also, for those countries that have already developed a plan or they are in the process and have gotten somewhere, we need to test that prototype. We cannot just develop a policy and then think that somebody's going to invest in it. We have to test it and generate the evidence that it can actually work and improve health systems and health outcomes. We need that evidence. We need to demonstrate impact on health system strengthening, on health outcomes, and we also need to demonstrate impact on the social economics, like I said. And then we also need to learn lessons on how it can be done. Once you have the policy, once you have the NSOAP, how do you really scale up? Because there's no country that develops a policy and then implements it countrywide. It can't happen like that. It's never happened. We have to pilot it first, learn lessons, and then we can scale up, and also we can use that for best practice. And then, of course, when we demonstrate that impact, generate the evidence and the lessons, I'm sure it will be possible to attract the funding that we are looking for, which also has to be very innovative, looking at domestic financing more than looking at external finances. Thank you, and sorry for the hitch up with the technology.
Well, thank you very much, Emmanuel. Once again, you've given us a very passionate talk on the realities of all of what you're doing down in SADC and around the world. So thank you very much. Now, I just want to shift gears quickly. This special webinar is actually for the launch of the NSOAP Manual. And so what we're going to do now is I'd like to have Sebastian provide a link in the chat zone where you can go and register to get a free copy of the NSOAP Manual. And please do go and download it. Sebastian, I can see, just put it into the chat box, that link there. The other thing I'd like to mention, which is very important, is this special launch, publication launch, is the first of 7 online event series, each dealing with a high-level approach or topic related to the NSOAPs. On October 14th, it'll be the first-hand experience of developing an NSOAP. Number 3 is how to integrate that NSOAP into national health and pandemic response strategies. Then we carry on further on into November with the donor's perspective, the Ministry of Health perspective, the role of NGOs, professional societies, and academic institutions. And then a very pragmatic approach to what the first initial steps are to starting an NSOAP. And we are going to have many of our partners. We want to engage the broad spectrum of surgical care, most importantly, anesthesia, children's surgery. There's a number of partners who are going to be working with us on this series, and we're really excited for that. Now, by registering for this first one, you will be able to get an email to alert you to the upcoming webinars. So that is already in process. And so I just wanted to alert you to that upcoming series. So thank you very much. Now
Hey,
that you
Jeff?
have, yes, go ahead, John.
I'm sorry to interrupt. I just, vis-a-vis anesthesia, I just want to make sure that we highlight the importance of anesthesia. And for example, I'm looking at the photograph from the Dubai meeting in 2018, and Janica Mellon-Olsen was there in that first Dubai meeting. And she's now the president of WFSA. WFSA has played a huge role in this whole process. Adrian was actually at our meeting in 2019, Adrian Gelb, and he'll be taking the baton as president of WFSA. But the main reason I want to mention that is that I have to give a little shout out to Janica Mellon-Olsen because it is her birthday today. So I want to wish her a happy birthday. She has been a wonderful friend and colleague, and really been a driving force, not only in the anesthesia community, but in the greater global surgery, OB anesthesia, trauma community. So Janica, if I hope you're still on, I see your name there, but I just want to say happy birthday to you. So Jeff, with that, I'll turn it back to you.
Well, thank you, John. And really, it is so important to remember that when we say surgical care and services, it's a broad spectrum of partnerships. It's not just about surgery. It's about safe anesthesia, about good nursing care. It's about rehabilitation. It's a broad spectrum of things. So as you're downloading the link for the NSOAP manual, I just want to take a few minutes. We're a little bit over the 4 o'clock mark, but I just wanted to take a few minutes for questions and answers. There's been a number of good questions that have come in. And one of them that is being repeated is from several people from around the world. How do I get involved? I'm a surgeon and I want to be more involved. How would I get involved? So maybe, Salome, I'll ask you to quickly answer that one. And then I have another couple of relevant questions before we end our session today.
Thank you very much. And I mean, just to emphasize, this has been built over many years with many of us partnering, developing this. Global surgery is a growing discipline. Initially, it was in high-income countries, and as Africa, we're working together across the continent with different groups to make this happen. And so a lot of the work in Africa has started on academic institutions. And so in South Africa, for example, UCT, WITS with Emmanuel Makasa, Stellenbosch, and there are a lot of other places. The SADC community, we meeting regularly to discuss this. So I think you can get involved by contacting any of us, whether, I saw there were a few people from Germany, from different places. I think it's really contacting any of us who are in the global surgery world. We work very closely together. We linked quite closely, and I think it's just contacting any of us to see how you can get involved. But I think most importantly, what I want to say, it's all about partnership. And so our team is diverse. We work with civil engineers who are looking at infrastructure. We work with scientists. We work with, so it's not just about surgeons. It's not just about clinicians. But I think there's a space for anyone who firmly believes that no one should die from surgical complications or from not having access to surgical care, and finding a place and space to get involved in being part of that vision and mission. Thank you.
Thank you, Salome. That's very good. And I just want to switch to one other question. Anil Shrestha from Nepal actually brought up something similar, but let me just ask our panelists. In the effort to achieve universal health coverage, it's becoming increasingly evident that surgical care systems, including safe anesthesia, obstetrics, nursing, rehabilitation, can form the firm foundation for a strong, resilient, and sustainable healthcare system. And yet we're still struggling to gain traction in it having become a global health priority. So the question to you, just one key message you would like to share with the world's global leaders from each of you, including the major funding agencies. How can we get it to become a global health priority? John, let me start with you.
Well, I think we need to get out of our comfort zone a little bit. And I said this a week or two ago at another webinar. You know, for example, with financing, we kind of live in a little echo chamber of our own, global surgery community, but we need to reach out into the financing community. It isn't an area that we normally live in, but those are the folks that we need to talk to about how to finance these types of things. And again, what about the global health security community? That's a separate community from ours. Some of us have some inroads there, particularly if we're in the trauma world. But I think the global health security and pandemic preparedness world, we really need to partner with them as we've learned how important global surgical capacity is for pandemic preparedness. So I think we need to get out of our comfort zone and engage different groups that are important.
Thank you, John. Salome, do you want to add to that?
Yes, and for me, for us, it's all about implementation, and the starting point is firstly, I mean, we've identified the problem, we've got a plan, we've got a manual, and now let's use all of that to implement change and to improve surgical outcomes for all.
And Emmanuel?
Yes, indeed. During on what the other speakers have said, I can add that, like I said, there is a very strong need now for us to translate the policy. We have, like Dr. Salome, Professor Salome has said, we have a manual that can guide you on how you can develop the policy at country level. We have a lot of partners that can help you to actually do that. But again, here in the Republic of Zambia, we did develop the policy. We are 2 years or 3 years down the road. So we're doing a midterm review now, but even just it's being assessed. But overall, we know that our progress has been very slow. Even financing this policy has been very, very slow, even when it's already integrated in the National Strategic Plan, which is part of the 7th National Development Plan. So where it comes to integrating these policies and making them part of what's already there, we've done that. But we still are not seeing any investments in this area. And I think mostly it's because we have not translated or prototype, proto-tested that. Can we, as a surgical community or the global surgery community, go and take on a district hospital facility and ensure that we can provide the emergency and essential, appropriate emergency and essential surgical services at that facility 24/7, doing everything else, monitoring everything else, the referrals, the patient outcomes, and then so we can demonstrate how surgical service capacity building is going to improve outcomes in the other siloed systems that are already very well funded. Okay, we have to show that impact. We have to show and bring that evidence so that the others can see the usefulness of this piece that we keep preaching to them. Until we can scientifically, properly demonstrate that, we will continue to struggle because nobody understands what we're talking about. It's pretty complex for them maybe, but let's show that. If we can show that and then work with the community by mobilizing them, because they're the recipients, they're the owners, they're the ones we're working for. So they can speak for themselves as well. Because sometimes some of us can't speak very, very well, very, very strongly, or, we are guided by ethics and a lot of other things. The community themselves can speak another language. The NGO world, the civil society, how can we bring them on board? Because if you look at any other program that's been very successful, including HIV, it has a very strong community engagement and a strong community, platform. So we have to start doing that. Besides what John and Salome has said, we have to go in that direction. Let's demonstrate the impact and usefulness of surgery. Let's engage the community and civil society so they can work with us to mobilize what we are looking for.
Well, thank you very much, Emmanuel. Very, very wise words of advice. So now with that, I'd like to now turn it back over to Alex Mejia. And I just want to say a few words of thank you to the whole team involved with making this happen. I want to just say again that we're very excited about this 7 series online event that we have coming up. And we'll send you information for all those who have signed on to this webinar. And also with the completion of all of that series, there is a certificate of completion offered by UNITAR. So just for interest's sake. So we're very excited about that overall series that'll go into the beginning of the next year. So thank you once again to all of our speakers. And Alex, I'd like to turn it back over to you. The floor is yours. Thank you very much.
Thank you, Jeff. Thank you to all the panelists. Let me close the circle very succinctly. NSOAPs are critical for sustainable development, for the global fight against poverty, and so we can indeed improve the quality of life of the citizens of this planet, mainly in the developing world, but not only in the developing world. So as you have heard, that this manual indeed can help countries to bring to reality, to bring to fruition this intention to improve in a holistic manner surgical care. I invite you again on behalf of UNITAR and the Program in Global Surgery and Social Change of Harvard Medical School to be part of the solution, to indeed learn more about it. If you're a practitioner, if you are involved, as you heard from the previous panelists, do something. Be part of this process. And if you simply have some curiosity, indeed, learn about it, because you can be a beneficiary of an NSOAP. With that, I'm thanking again Dr. Mera for co-hosting this webinar, and both professors and our own Dr. Ibbotson. I thank everyone for participating, and on behalf of UNITAR, we declare this meeting adjourned. Thank you so much. Goodbye.